The European League Against Rheumatism guidelines for the gout advise the oral colchicine and non-steroidal anti-inflammatory drugs as the first-line agent for the treatment of acute attack of gout. In the absence of contraindications, an NSAID is a convenient option. Let's take a look at them one by one, and let's have a look at the underlying mechanism of actions of these drugs. As far as the colchicine is concerned, it's effective, and a low-dose colchicine appears to be as effective as a high-dose colchicine. Since colchicine can have unpleasant side effects, including severe diarrhea, bone marrow, and neuromuscular dysfunction, using a lower dose of 0.5 milligrams thrice daily is advisable. When NSAIDs are contraindicated, a short course of low-dose oral prednisolone therapy may be preferable and is the treatment of choice for severe polyarticular flares. As for the corticosteroids are concerned, there are no controlled trials comparing steroids with placebos for acute gout. A systematic review of identified 6 comparative studies comparing corticosteroids with NSAIDs for acute gout, they didn't find any difference in response to treatment between the two treatments. However, people taking NSAIDs had more gastrointestinal side effects. The clinical experience supports the use of intra-articular steroids, but septic arthritis must be positively excluded in these cases. Intra-articular injections in acute gout can be difficult and very painful, particularly for the smaller joints. Patients with gout are often prescribed with analgesics because gout is extremely painful. Patients may need potent analgesics in addition to specific treatments. For some frail patients, just using analgesics may be appropriate. The miscellaneous treatments through controlled trial evidence suggest that some non-drug pain relief modalities, such as the use of ice packs, may give additional pain relief. The monoclonal antibody such as canakinumab is licensed for the treatment of acute gout. If conventional treatment is ineffective, but its cost is prohibitive. The target serum uric acid levels is 360 millimoles per liter, according to the Euler guidelines. This treatment should ideally be deferred until the acute attack has settled, otherwise the attack may be prolonged. NSAIDs, colchicine are continued for the first 3 months of hypouricemic therapy because the risk of the further attacks remains as the urate levels flux between the different levels. Now, along with all these treatment modalities, diet and more usually alcohol intake may need to be adjusted. This was all about the treatment of the acute gout. Now let's move on to the treatment of chronic gout. Remember, the mainstay of treatment for the prevention of recurrent acute gout or chronic gout is reducing the serum urate enough to allow crystals to clear. Different authorities suggest the levels to be less than 0.30 millimoles per liter or less than 0.36 millimoles per liter as the therapeutic target. Less than 0.30 millimoles per liter is appropriate if tophi are present. Asymptomatic hyperuricemia does not require treatment. Patients with 2 or more attacks of gout per year should be offered urate-lowering medications. Usual advice is not to start the urate-lowering drugs during attack, as this may delay the resolution and should be avoided, as the lowering serum urate can trigger an acute attack. An NSAID, probably with a proton pump inhibitor or colchicine, should be co-prescribed for the first 3 months. Medication review considers stopping diuretics or any other drug known to increase the serum urate levels. On the other hand, we have to advise the patient to reduce the alcohol intake or avoid beer. They have to increase the intake of low-fat dairy products. Lifestyle interventions are also advised, and the patient should be advised to lose weight if appropriate and reduce meat and fish eaten. Xanthine oxidase inhibitors have also been a part of the treatment. These prevent the purine breakdown products, xanthine and hypoxanthine, being converted into urate. Allopurinol has been available for nearly 50 years. More recently, a second xanthine oxidase inhibitor, febuxostat, has become available. As for the allopurinol is concerned, it reduces the serum urate, but its effect on recurrent gout is unclear. Only a minority of patients taking the typical dose of 300 milligrams per day achieve a target urate of 0.36 millimoles per liter. Its dose should be titrated according to response up to 900 milligrams per day. Allopurinol hypersensitivity may occur in up to 2% of patients. This can be severe or even fatal. Desensitizing regimens of allopurinol can be tried in milder cases of hypersensitivity. Moving on to febuxostat. Febuxostat 80 milligrams is superior to allopurinol 300 milligrams at achieving a serum urate of less than 0.36 millimoles per liter. However, febuxostat does not appear to be more effective at reducing the recurrent gout over 1 year. It may have a role in patients who cannot take allopurinol either because of intolerance or because it is contraindicated due to some other reason. Now moving on to the uric agents. Now these drugs lower the serum urate by inhibiting its tubular reabsorption. There is no study evidencing or supporting their use for prevention of recurrent gout. Only sulfenpyrazone is generally available for the treatment of gout. Benzbromeron can also be used, but it is not universally available, and there are concerns about it causing liver problems. Historically, probenecid has also been used. Now, selective uric acid reabsorption inhibitors are being tested and may become available. One should consider measuring urinary urate before starting uric agents. The use of NSAIDs and colchicine should be regular, and they can be used to prevent the recurrent gouty attacks but have no effect on the serum urate levels. The uricase drugs work by oxidizing the uric acid to more soluble allantoin and are available in some jurisdictions. Then we have a lot of miscellaneous drugs as well. Coincidentally, they have been found to have the urate lowering effects. These drugs include the losartan, fenofibrate, atorvastatin, and amlodipine. Although they are not licensed for the treatment of gout, they may have a role if other drugs cannot be tolerated or if they are otherwise indicated for patients with multiple pathologies. So I hope you are now well versed with this condition of gout. Stay tuned for more related concepts and conditions such as pseudogout and Leschnahan syndrome to further clarify your concepts.